He did his fellowship then in TCD, transcranial Doppler, and carotid ultrasound, followed by a fellowship in neurocritical care, followed by a fellowship in interventional neurology. And he has written several articles in critical care medicine in International Journal of Stroke and Archives of Neurology. He is an associate editor of two textbooks, Atlas of Interventional Neurology and Textbook of Interventional Neurology. He is currently an assistant professor at Baylor College of Medicine in Houston, Texas. I would like to welcome Dr. Alex Georgiadis. So far, it has been a feast for me, and I'm sure for all the postgraduates here, you are feeling the same.
Okay. Do I have a pointer of some sort, or you have a? No. This happens to me all the time. The computer switched the font again, so the things are moved like right and left. Like that one doesn't belong there. You know, it should be up there. So we'll have some technical problems. But anyway, so this is going to be a talk about subarachnoid hemorrhage, which is a very broad subject. So I tried to quickly summarize the most salient points. Yeah. So we'll start with some facts about cerebral aneurysms. Aneurysms are considered to be acquired lesions as opposed to other vascular malformations of the brain, such as AVMs. They form in vascular segments that are exposed to abnormal flow patterns or increased stress in general, such as bifurcations, and most of them tend to be located in the circle of Willis. People with a family history, especially if they have first-degree relatives who are affected, are at increased risk, but you don't see a lot of familial clustering. So for the most part, it is a random, aneurysmal rupture is a pretty random occurrence. There's a lot of risk factors that have been identified, such as hypertension, smoking, and heavy alcohol use. But it's important to keep in mind that the majority of aneurysms do not rupture in life. And so when people have unruptured aneurysms, it's a kind of a challenge to know when to treat them and when not. There are a lot of statistics out there, for example, that anterior circulation aneurysms tend to rupture more. But the most important thing to keep in mind is that generally aneurysms are treated when they exceed 7 millimeters in size. Okay. Now, subarachnoid hemorrhage is relatively rare. It makes out 3% of all strokes, approximately. So it's an incidence of about 5 patients in 100,000 patients. 5 cases in 100,000. Traumatic subarachnoid is the most common form, but it's a more benign entity and doesn't have the complex management that aneurysmal subarachnoid hemorrhage does. Subarachnoid hemorrhage also is important to know. It affects young people a lot, much more commonly than other types of hemorrhage in the brain, but still the incidence increases with age. And mean age at onset is approximately 50 years. And women are slightly more often affected than men are. So as I mentioned, aneurysmal subarachnoid hemorrhage is a complex condition, and it predisposes patients to all kinds of complications for which they need to be monitored. So an average stay in the ICU should be a minimum, at a minimum, about 10 days. The median mortality remains very high at about 30%, even though there have been improvements obviously lately, but it's still very high at 30%. And of the 70% that survive, half of the patients have significant disability, and it's usually a mix of physical and cognitive behavioral disability. And however, you do see in subarachnoid hemorrhage, of all conditions, patients who come in extremely sick and can achieve excellent outcomes. Now, well, I'll talk briefly about the diagnosis of subarachnoid hemorrhage. You've probably all heard of the classical presentation, the textbook worst ever headache. So that is true in most cases. Even more important than the severity, though, is the fact that the headache tends to be of maximal intensity at onset, and that is what we mean by thunder fell to the ground. And there's multiple potential explanations for that. It could be because of the sharp ICP rise that you lose consciousness. It could be because of seizures. And actually, it could be because of cardiac complications that are fairly common, as we'll see as we go on. And a significant proportion of patients does not even make it to the hospital, and that's believed to be in excess of 10%. And that was not even included in the 30% mortality that I quoted before. Some patients may have what's called sentinel headaches, which are milder headaches, but still unaccustomed headaches that occur before the major headache. But for the most part, subarachnoid hemorrhage tends to be very random and abrupt. Now, for general clinicians, the most important thing to know so that you have the correct mental picture of what subarachnoid hemorrhage looks like, and again, I'm sorry for the completely distorted slide there, is that focal neurologic signs are rare. So the typical picture is a drowsy patient who has a headache. You should not expect a subarachnoid hemorrhage to have a hemiparesis, for example. That is extremely rare. All you can see in some occasions are really oculomotor findings. You can have restricted upgaze, you can have dilated pupil, you can have things of that nature. You can have a pseudo-sixth palsy, but a frank hemiplegia, for example, with subarachnoid hemorrhage is almost impossible. And that helps distinguish subarachnoid from other types of hemorrhage and from stroke. Now, the mainstay of diagnosis is CT of the head, a non-contrast CT. And it has excellent sensitivity, almost 100%, if it's done within 12 hours of symptom onset. The problem with CT is that the sensitivity drops quickly, and it drops down to 50% at 7 days after onset. So what that means is that if you have a negative CT, but a presentation that is suggestive of subarachnoid hemorrhage, you are pretty much obligated to do a lumbar puncture. The things you would look for in a lumbar puncture are obviously an elevated RBC count, and you have to check in consecutive tubes to make sure that it's not a traumatic tap. So if you have a lot of blood in tube 1 and hardly any blood in tube 4, that's likely to be of traumatic origin. Then you can examine visually or in the lab via spectrophotometry for xanthochromia, which is pretty much the most important finding. And in some cases, you'll find elevated ICP if you do an ICP measurement during the tap. So what are the immediate goals when you see a patient like that in the emergency room? Obviously, you start with assessing the patient for his ability or her ability to protect the airway. You have to treat seizures if they're present. And and then after the ABC portion of this and the seizure treatment, you have to take a very good look at the CT. And as you see here, in this CT, you see the classical finding of blood in the cisterns here. And there's actually some blood, some cortical blood here in the Sylvian fissure. But it's very important to examine the CT for hydrocephalus, which you clearly see here. You see the tips of the temporal horns and how enlarged they are, and you see the ballooning of the third ventricle. So, the subarachnoid hemorrhage is something that everybody pays attention to. So the most important thing to look at, though, is the hydrocephalus. And why? Because the clinical picture can be completely altered by hydrocephalus. You can have a patient who comes in looking quasi-brain dead, like having no exam at all, who you could potentially write off. And the patient can wake up and be completely normal virtually after an EVD is placed. So your assessment in a patient with hydrocephalus before an EVD is placed is not complete. Now, And the issue with this is, so that's one part, is to understand exactly how bad the situation is. The second thing is that the first line emergency in subarachnoid hemorrhage is treatment of the ICP, because as the bleed causes your ICP elevation, your intracranial hypertension, you have a reduction in cerebral blood flow. So the longer this goes on, the more exposed the brain is to global ischemia, and the more, the worse the outcome is going to be. So, because remember, the cerebral perfusion pressure is the mean arterial pressure minus your ICP. So when the ICP rises towards, and starts getting close to the map, you have very little brain perfusion, which is another thing, and that points to another thing that people don't always think of, and that is that I think that blood pressure should not be lowered aggressively before an EVD is placed. You don't know at that point what the ICP is, and if a patient is unconscious and you severely drop their blood pressure before you put in the EVD, I think that you're exposing them to much more ischemia, potentially. Then patients who are sick, it makes all the sense in the world to intubate them, not just for airway protection, but also because you can manipulate their vitals. You can sedate them as much as you want, and you can do pain control, so that avoids spikes in blood pressure and potential rebleeding. Now, once the EVD is placed, generally you'd want to keep the blood pressure at less than 140 or 160 systolic. The official guideline is less than 160 for some reason, but I mean, in real life, usually you'd use less than 140 or even lower than that. So once the patient's been stabilized and these things have been taken care of, the next step is to do testing to identify the source of hemorrhage. And the two tests most commonly used are CTA and DSA, so conventional angiography and CT angiography. CT angiography, especially if you have a newer machine, like a 64 slice machine, for example, is almost equivalent to a conventional angiogram at this stage. So what is actually done depends on the way the institution is built, the availability and things like that. Now, if you have an aneurysm, then you can identify it. The goal is to secure it within less than 24 hours. Really, the sooner the better, but the goal is at least within 24 hours. And why is that? It used to be that people said, we'll let the brain chill for a few days, we'll take care of the patient for 2-3 days, and then do the surgery under more controlled circumstances and have a better outcome. But the problem is that the re-rupture risk for aneurysms is very high. So it's 1 to 2% per day. It's highest in the first day, and the cumulative risk over 3 days is almost 10%. So by delaying the surgery, you expose people to the risk of re-rupture, and that carries a very, very high mortality. Now, and what do you do if you don't find an aneurysm? Pretty much, you admit the patient to the ICU, and you repeat your CTA or angiogram at least once. If a hemorrhage really looks like an aneurysmal hemorrhage, I think in most cases it's justified to get a total of 3 tests, actually. Now, and you don't always find aneurysms, though. Even if the hemorrhage looks aneurysmal, meaning that it's located basically in the cisterns, so it's not a cortical hemorrhage, there's no history of trauma, so there's no reason to think that there's reason to think you have an aneurysm. You only find them in 80% of cases. So in 15% of cases, you find no reason for the bleeding at all. And many of those are what are called perimesencephalic. So there's less blood, it tends to be in front of the midbrain, and it's believed to be possibly of venous origin, and it's an altogether more benign entity with a much less complicated course. And in 5% of cases, you'll find alternate etiologies, such as AVMs, which is the reason why you should consider doing an MRI of the brain or the C-spine or the C-spine. And then really rare things like vasculitis and intracranial dissection and so on and so forth. Now, there are a number of grading scores that can be used. The two that correlate with clinical outcome are the World Federation of Neurological Surgeons scale and the modified Fisher scale. And I'm not even sure why you need the scales, because if you look at it, all it tells you is you do better if you have less blood on the CT and if you're awake and are moving. So, which is pretty, I think, self-explanatory. A scale that's used, I'm sorry, again, things have shifted because of the different font. So a scale that's used a lot is the Hunt and Hess scale. It's still used a lot. Even though this was really primarily devised to assess for operative risk, for surgical risk. And you'd say that, for example, candidates, patients with a grade 4 or 5 would generally not be considered appropriate for surgery. So the problem with all of, with scales like that, is that the exam is pretty dynamic. When you see, for example, when you say somnolence, confusion, focal deficits, I mean, these things can change in subarachnoid hemorrhage very quickly. Now, like we said, treatment should be pursued pretty much immediately. So definitely within 24 hours. And there are two main options available: coil embolization or stent placement, so endovascular, and surgical clipping. Now, coiling has, in general, coiling has less immediate complications. It's better tolerated. And it also is associated with more favorable functional outcome. On the other hand, clipping offers higher rates of complete obliteration and lower rates of recurrence and need for retreatment. But as years go by, advancements in endovascular technology are closing the gap, so that nowadays, if aneurysms are amenable to both treatments, coiling is generally recommended. And these are some of the factors that weigh into your decision how to treat the aneurysm. Obviously, poor surgical accessibility, let's say a tip of the basilar aneurysm, is something that makes you think of an endovascular approach. A large neck to dome ratio would, tip you more towards clipping. If you have an anatomy that's very complicated, for example, with arteries arising from the dome of the aneurysm, that tips you towards clipping again. If the patient's old or has a horrible cardiovascular system, that makes you more likely to do endovascular. Then there's cases, for example, let's say you have a large ICH that you want to evacuate, then you can combine that with the surgery for the clipping. But at the end of the day, it also comes down to operator experience and availability. So this is just a quick overview of how aneurysms are treated endovascularly. You see an ACOM aneurysm here. You see the microcatheter positioned in the dome of the aneurysm. Through the microcatheter, coils are extruded that fill the dome and essentially prevent filling. Now, and I wanted to quickly go through a number of medical issues, like the medical management, pretty much, of subarachnoid hemorrhage. So, is there a role for procoagulants? I just heard about aminocaproic acid for ICH. In general, when you use procoagulants, you do achieve less rebleeding. So that is a fact. The problem is that is offset by a large number of thromboembolic complications. So in the end, it has never been shown that drugs like aminocaproic acid offer any benefit. So you can make a point that you can use them if you cannot get treatment for the patient quickly enough. So if you anticipate that the patient's not going to be treated for 3 days for some reason, then it might be a logical option. It should depend on the general, profile of the patient. If this is a patient with stents in the heart because of horrible CAD, you should be very careful, giving a patient like that aminocaproic acid. And in any case, duration of the treatment should not exceed 3 days. Now, in terms of anti-epileptic medications, it used to be that everybody was loaded with Dilantin and stayed on Dilantin for something like 3 months. Now, that has actually been shown to have had a poor effect on the people with worse outcomes. What we do today often is we consider a short-term course, usually 3 days or 3 days to 7 days, and usually it's something more benign like Keppra, like levetiracetam. If the patient presents with seizures or has ongoing seizures, you can consider prolonging the duration of the treatment. But we no longer really do routine, longer-term anti-epileptics. So, and just some general goals of management. You want the patient to be normothermic in all conditions, all diseases of the brain. Fever is a very bad idea. You want the people to be euglycemic, like at a range of 80 to 200. And as opposed to what we did before with forced hypervolemia and hemodilution, where you would place central lines and keep the CVP artificially high at close to 12, we really aim for euvolemia. So you want a euvolemic patient. The only thing that's important is to avoid dehydrating them. But we don't really chase their CVP anymore. In terms of blood pressure, the official goal should be keeping it at less than 160, MAP less than 110, before the treatment. After the aneurysm is secured, you liberalize the blood pressure management, so you can let them ride higher. And a very important part is DVT prophylaxis, which should be started generally 24 hours after the aneurysm is treated. Now, and keep in mind, for all of those patients, it's very important to assess their cardiac contractility by echo. And the reason for that is that the surge of catecholamine release that follows after subarachnoid hemorrhage has a lot of, produces a lot of cardiac complications. A large number of patients will have troponin elevation, EKG changes, arrhythmias, and wall motion abnormalities. Now, the most extreme form of this is what's called Takotsubo cardiomyopathy, which is what you see here. It's pretty much a complete akinesis of the apex that gives the heart this balloon shape that you see here, which was reminiscent of this device that the Japanese apparently used to trap octopuses in. So, and that's what Takotsubo means. But it's a reversible, very severe cardiomyopathy. So, and apart from the cardiac complications, there's also the equivalent pulmonary complications. So about 80% of patients will have evidence of impaired oxygen exchange, and 20 patients will have symptomatic complications that can range all the way to pulmonary edema and frank ARDS. So you will see the occasional patient coming in with a whiteout of the lungs and not even being initially diagnosed with subarachnoid hemorrhage because of the predominance of the pulmonary symptoms. Of course, that's rare. That's a rare presentation. So, and how do you monitor in the ICU? A big part of it is daily TCDs. So it's a bedside exam, and you monitor for vasospasm with this. You have to keep a close eye on electrolytes, especially sodium. Sodium is almost ubiquitously abnormal in people with subarachnoid hemorrhage, and most of them will become hyponatremic at some point. Whether it's SIADH or salt wasting, so an excess of ADH or a loss of salt in the urine doesn't really matter much, because in most cases you'll still treat with hypertonic saline because you don't want to risk dehydrating the patient if you're wrong. So, so you have to keep an eye on electrolytes. Then people who have, patients who have decreased level of consciousness or poor exam are often monitored with continuous EEG because subclinical seizures can otherwise not be ruled out. And then, there's more extravagant things that you can do, such as, brain tissue oxygenation monitoring, ICP monitoring. ICP actually is monitored through the EVD when you have an EVD. But, and then perfusion scans are something, that's something that can help if you have a patient with a poor exam and you're not sure if they're having spasm and are underperfusing their brain. So this is an example of what vasospasm looks like. You see all of these segments here where the artery is narrowed, and you see the clear difference after administration of intraarterial milrinone in this case. So vasospasm has a very complex and poorly understood pathophysiology. The problem is that it's not normal spasm. This is not what it's about. It's the wall of the artery is inflamed, it's hypertrophic, and it reacts very abnormally. It doesn't respond very well to vasodilators, which is, part of what you do is you can administer intraarterial vasodilators, but the artery cannot simply be dilated. The more blood you have in the subarachnoid space, the more likely you are to get vasospasm. And the thought is that metabolites of hemoglobin irritate the vessel wall and lead to this. But there's a very complex chain of events that includes vasoconstrictors like endothelin-1 and a host of inflammatory factors. Up to 70% of patients with subarachnoid will have some type of vasospasm, but only half of them will be symptomatic. And that's what you really care about, that's symptomatic vasospasm. If you have spasm and you have a completely normal exam and you're awake, all you do is that you monitor more closely. So the peak incidence is at 4 to 10 days after subarachnoid hemorrhage, but it can be seen earlier and in some cases a little bit later than that. And the spasm is often found near the aneurysm, and it can be focal and can be completely diffuse. It's a big part, spasm is a big part of overall morbidity and mortality. And keep in mind, again, for the more general practitioners, that the most common presentation of spasm is not focal signs, like you would expect, because in many cases it is a focal spasm, right? But the vast majority of cases present with decreased level of consciousness. So we have, like I mentioned before, the TCD, which is a bedside test that's a very easily available tool with which you screen, and we can establish a diagnosis with that. And in cases where you think that your Doppler is showing you spasm and the patient is altered, you will proceed with angiography with DSA, where you can do, there's like a couple of things you can do, like intraarterial vasodilators, and in some cases angioplasty, depending really on the severity of the condition. Now, if the patient is still hanging in, you might be able to use induced hypertension or inotropes to see if you can avoid endovascular intervention. And I just wanted to mention all of these terms a little bit because they're very confusing, and they're many times used interchangeably and just make things very difficult to understand. Delayed cerebral ischemia is pretty much self-explanatory. The problem is that it's used instead of vasospasm many times, but vasospasm is really a radiographic diagnosis and DCI is a clinical diagnosis. And then delayed neurologic deterioration, which you'll read in many articles nowadays, includes a whole host of different things that can make the exam worse. So it could be DCI, vasospasm, it could be seizures, it could be infection, cerebral edema, hydrocephalus, like a host of things. So, and how do you diagnose DCI? It's easy when the patient is awake because you'll be able to examine them and see the change. It's hard to detect in poor grade patients. And tests that can be used if you're not sure are the TCD as mentioned before, where velocities of greater than 200 centimeters per second and the Lindegard ratio, meaning a MCA to ICA velocity ratio of greater than 3 to 6. I mean, those are diagnostic for vasospasm, right? You can use EEG, where you can see reduced alpha variability. You can use cerebral oxygen monitors. And you can use, of course, vascular imaging or perfusion imaging. Anyway, this was very tightly packed, and I hope I didn't give you too much in too little time. Overall, subarachnoid hemorrhage is a severe condition with complex, very complex neurological and medical management. There have been a lot of advancements in neurocritical care that have improved outcome, and outcomes are indeed better in specialized centers. So it is important to send people from low volume to high volume hospitals. But morbidity and mortality remain very high. The goal when you admit a patient with subarachnoid is to diagnose them promptly and to treat the ruptured aneurysm as soon as possible, definitely within 24 hours. And as years go on, endovascular treatment is replacing clipping more and more, and it's already becoming the predominant mode of treatment. So that was it.
I think there are thoughts for questions. I think one of the things that Dr. Georgialis mentioned is the time to treatment. And in patients who have a ruptured intracranial aneurysm, the maximum chance of actually having a second rupture or rebleeding is really in the first 24 hours. So now in the metrics for comprehensive stroke centers in United States, they actually mandate that centers maintain the time to treatment. So the time when the patient actually came to the hospital to the time they received a definitive treatment, whether it is surgical or endovascular. And also maintain the number of patients who actually got treatment within 48 hours of actually having the first rupture. And again, all of that is to promote a quality measure, which is to minimize the time from symptom onset to actually treatment of intracranial aneurysm. The other point I wanted to mention, which Dr. Georgialis also alluded to, is that there are, in cerebral vasospasm, the term is almost somewhat a misnomer because what is happening in the arterial wall is more than just smooth muscle spasm. In fact, there are actually true structural changes, which is proliferation of myofibroblast and actually increase in the collagen content of the blood vessels that actually give the appearance of narrowing. So it is really more than smooth muscle spasm. And that is why the most definitive treatment for cerebral vasospasm is primary angioplasty. So you can actually use intra-arterial vasodilators, but with the understanding that the effect is going to be temporary and there is a very high rate of recurrence of cerebral vasospasm after using intra-arterial vasodilators. So essentially a sustained treatment really requires the primary angioplasty of the affected blood vessel.
Any questions?
Treatment option for multiple Bleb aneurysms.
I'm sorry?
Treatment option for subarachnoid hemorrhage due to multiple Bleb aneurysms. Bleb aneurysms.
Oh, well, it really depends on the center where you're at. Are you also implying that you're not sure which aneurysm has bled, or?
No, it's BLE, Bleb. It's
Oh. Yeah, yeah. Well, and your question was, what are the options?
Yeah, I mean they are not surgically can be clipped, neither they can be coiled or glued, and there are multiple, say, in ICA-MCA bifurcation, and has called perimesencephalic cyst. Perimesencephalic bleed.
Yeah.
And in MR angio or CT angio, we don't pick up. And DSA, there are multiple Bleb aneurysms, small Bleb aneurysm, BLEB.
Yeah. Well, I think that there are surgical options for those. I think that you can wrap the, you can do wrapping of the artery. There's no endovascular option, but there are surgical options, which are not very easy, though. I think it's a fairly...
I think that it's a very interesting question because now there's more emphasis on these blister aneurysms or blebs, and them actually being a source of the primary subarachnoid hemorrhage. And in terms of treatment options, they are actually difficult. So surgically, putting a clip is very difficult. So unless you're willing to sacrifice part of the artery, so you would actually have to indent into the parent artery to actually get a definite grasp on the blister aneurysm. In terms of endovascular treatment, there is actually more data supporting flow diverting devices. So actually putting a flow diverter in front of the blister aneurysm with the hope that you've broken the shear force on the wall, and then over time that would just thrombose off. But as Dr. Georgialis mentioned, primary coil placement is not an option. It's just too small a sac to really hold a coil in there. But nonetheless, they actually do represent, they are actually challenging. And I do actually have recall seeing complications in these kind of patients, either with coil placement or even with clip placement, because essentially sometimes we get the sense that we can put a clip across it, and then during surgery is the first time you realize the clip just keeps slipping off that small sac.
What is the ideal dose for intraarterial nimodipine, and how long it should be given in a calculated or say already vasospasm patient who are having vasospasm? We are giving intraarterial nimodipine. I'm sorry, and
Oh, that's an endovascular question. I'm not intraarterial, right? Oh, PO?
intra.
In some countries. I think that I personally don't have any experience in intraarterial use of nimodipine. I think our experience really has been based on intraarterial use of nicardipine. And perhaps nicardipine, in addition to intraarterial magnesium sulfate, is some combination that we use intermittently. But I think in general, I think the belief is that vasodilators are not a sustained solution to vasospasm, and the rate of recurrence in the initial studies was cited as 50%. I think a more recent study would say it's almost like 80% recurrence chance in the next 24, 48 hours after using intraarterial vasodilators for cerebral vasospasm.
Thank you.
I just want to make a comment about small and blister aneurysms. Aneurysms, only if the size crosses 6 or 7 millimeters. If the aneurysm develops multiple lobes while being on follow-up, if there's a teat developing in the aneurysm, then these need to be treated. The only way you can treat them is by wrapping and then applying clip, otherwise clip will slip. Blister aneurysms are dorsal carotid aneurysms. Surprisingly, there is no internal elastic lamina there, and some of them are adherent to the frontal lobe. When you retract, they can burst. There are people who have used Dr. Sund's clip which encircles the carotid as a protective measure. That's about this. Thank you.
Your opinion regarding if we give intraarterial milrinone followed by IV milrinone for continuation to prevent recurrence of vasospasm. So because we are continuing IV milrinone.
Actually, let's see what Rakesh has to say.
Typically, my way of doing vasospasm is I evaluate patient clinically and transcranial Doppler. Transcranial Doppler is a good tool to have, but you have to see if the spasm is worsening. So kind of every day when you say daily TCDs, you are not just going by one absolute number, but you are seeing a trend. And if it fits well, then you start I definitely keeping them euvolemic, making sure their cerebral perfusion pressure, I keep my goal about 70 or above, and keep that going. Along with that, every patient is on Nemotop. That's a level 1 evidence-based. So you cannot skip Nemotop in these patients. And if patient is getting deteriorated, if spasm is getting better or clinical worsening, I take them for angiogram. Depending on if it is very proximal, high-grade vasospasm, which may be ICA, M1, then I tend to do intra-arterial followed by angioplasty. So angioplasty, so far, what I've seen is if you want to change the outcome, be aggressive from the get-go. So I typically give Verapamil, which is very well tolerated. You give 5 to 10 milligram in every vessel you go in. You can go selective, go very selective, but typically I start with just my diagnostic catheter. I give 10 milligram. So by the time I put my guide or microcatheter, already it's been 5-10 minutes. Medication has already started acting. If it is very distal, you can't reach there. So you take your microcatheter, go to M1, give some 5 more, come do your angioplasty, be done with that side. Depending on if it was symptomatic or not, you check your other side as well. Sometimes you may want to just check, you don't want to do angioplasty. So you would do diagnostic, just through diagnostic give intraarterial, go to the other side, give another Verapamil, come back, check. And sometimes that may show some improvement. I do not do milrinone at all. Cardine is not well tolerated. Every time you give 10 milligram, there is a drop. So verapamil is well tolerated. Magnesium sulfate we used to do a lot. So that's typically my management.
Time and thank you. We proceed for the next lecture.
The next talk, I'll tell a little thing about Dr. Alex Georgiadis. When he graciously accepted to come here, he made a deal with me. He wanted to visit Mumbai first because he had heard so much about Mumbai. So he visited Mumbai before Hyderabad, and I'm going to remember that. And it's a nice way to finish off our clinical review case. And I always mention, and I'm sure you all do, how important neuro rehab is for our stroke patients. And the importance of it is maybe in some places neglected, but this talk is a good way of ending, like I said, a nice clinical review session. And the speaker we have lined up for this is a phenomenal speaker. He is Dr. Abhishek Srivastava, who is a consultant in rehabilitative medicine. He is also the director of the Center for Physical Medicine and Rehab, the Kokila Ben Hospital in Mumbai. He is also a specialist in neurological rehabilitation. And I found this particular highlight really impressive. He's the first person to hold a PhD in neuro rehab in the country. And he did that from National Institute of Neuroscience in Bangalore. He also trained in US, he trained in Europe and Singapore, and he has several awards in neuroscience and rehabilitation, which includes the Young Physician Scholar Award by the World Stroke Association. He has several papers, chapters to his credit, and with about 13 years of experience in neuro rehab, in neurological, treating neurological diseases as well, we can be certain that we can learn a lot from his talk. So without further delay, I request Dr. Abhishek Srivastava to come and teach us. Thank you.
Thank you, Dr. Nabil, for the kind invite and the introduction. Thank you. So let's change tracks. We had an infarct, you have done the IV TPA, you have done the clot retrieval, you have a hemorrhage, you have done the evacuation, you have an SAH, you've done the coiling. What happens after 24 hours of that? For the patient, at the end of the road, only 1/3 of your patients do well with any intervention we are doing. 2/3 are still disabled. For families, beginning a burden. For physicians, it's still interventions. For organization, it's investment. You need money to treat those patients. And for the country, a loss of disability adjusted life years. And always remember, no two strokes are alike, of same gender, same MRI, and all strokes behave differently. So modern medicine has 4 facets now, and the 4th one is the rehab medicine. I'm a rehab medicine physician. The primary difference between a neurologist and a neuro physician is that the neurologist and neurosurgeon is more bothered about the anatomy, the pathology, the clinical diagnosis. So it's an artery which is being blocked or ruptured versus a rehab physician whose main target is what happens with that arterial rupture. It is the impairment or the disability. So what's an impairment? After any stroke, you can have aphasia, you can have cognitive issues, you can have behavioral problems, dysarthria, dysphagia, hemianopia, hemianesthesia, hemiplegia, incontinence. So our job as a neuro physician is to manage all these 8-9 things so we can prevent a disability. And the common disabilities are in mobility, you cannot walk, you can't do your own self-care, you can't think properly, you can't communicate properly, and you have incontinence. So our job is to prevent those, manage those 9 impairments, prevent these disabilities to happen, and if you have those disabilities, how to learn to live your life with these disabilities. The problem is how to train the brain. Is it so easy? No, it's very, very difficult. But post-stroke recovery always happens. Maybe 1%, maybe 90%. So it's variable. And the recovery can be a natural recovery, can be a functional recovery. So just see some facts. A neuro recovery can be a spontaneous recovery, which happens for 3 to 6 months, mainly by local injury get resolved to some extent. And this can now be targeted by newer interventions. We'll discuss how it can be done. Second is functional recovery, which is unlimited, because you can still train the brain to some extent by rehab interventions, even beyond 6 months. You might not change the impairments, but you can still reduce the disability after 6 months. So neuro rehab, the same lines can be compensatory or can be remediational. You can train a person to adapt to a limitation. So you can prevent a disability, well recognized. But can you actually restore the impairment? Can you actually treat aphasia? Can you actually treat dysphagia? Still poorly understood. But we'll discuss how it can be done. This is my favorite slide. How functions improve after stroke. So if you have ischemia, the MCA, left MCA, you can somehow stimulate the motor cortex. You can stimulate the supplementary motor area. You can inhibit the opposite motor cortex inhibition, or you can give some intervention to the involved extremity, or you can constrain the opposite extremities. These 5 broad principles are there on which all interventions are primarily based upon. So what are the actual mechanisms? In acute stage, 3 things happen after an infarct. We have reperfusion of the ischemic penumbra, the local edema gets resolved, and reorganization starts even in first few days after stroke. And these mechanisms are enhanced by IVTPA or clot retrieval, but now you can combine these interventions with drugs. There's a lot of role of memantine and donepezil to be given even in the acute stroke to prevent the worsening of aphasia. In next few days, subacute stage, 2 things happen. Brain can recruit additional areas to improve function. That's called as compensation. Or the main motor language area can be displaced to another place. It's called as reorganization. Brain's ability to compensate and do these 2 things is called neural plasticity. So plasticity is the most important factor by which rehab interventions improve the outcome of stroke or brain injury patients. Another concept is called as transcausal disinhibition. If you have left motor cortex involvement, the right motor cortex send inhibitory signals to the left motor cortex. You can do something with the right motor cortex to prevent that inhibition. That leads to more motor recovery. Again, this neuroplasticity can now be targeted by 2 things. By intensive training, called as experience-dependent plasticity, we'll see how it is being done, and also by biotreatments. You can actually add drugs now to improve the plasticity and also give magnetic stimulation to potentiate the action of that. What happens in the very late stage? Some brain areas of the uninjured hemisphere takes over the homologous counterparts of the particular hemisphere. Especially in the language areas, Gandolfi actually have shown how right brain takes over language function over 25 years in a patient with left MCA stroke. So cerebral cortex, which is billions of circuits, is the best site for plasticity. But remember, plasticity depends, is it different in different regions? It depends upon what experience, what treatment you are giving, what therapy, what training you are giving, what drugs you are giving, at what time you are giving. Is the person young or old, or he has a normal or injured brain previously? 6 common interventions are being done in literature. The first 3 currently are in research or trial stage. We'll not talk about that. The last 3 is therapy, can be physical therapy, occupational therapy, speech therapy, cognitive retraining, can be pharmacotherapy, drugs, and third, non-invasive brain stimulation, which are right now in phase 3 trials. Now come with this premise of how recovery happens, we'll apply this principle to stroke rehab. So guidelines say that all patients with stroke who are admitted to hospital and who require rehab should be managed in a comprehensive or a rehab stroke unit by interdisciplinary team. It's mandatory in America and Canada and Europe. And the interdisciplinary team should assess these patients within 24 to 48 hours of admission and develop a comprehensive individualized rehab plan which should reflect the severity of stroke and goals. And third, stroke unit team should conduct at least 1 formal interdisciplinary meeting a week to discuss problems of these patients. So it simply says all patients who have a massive stroke requires inpatient rehab by a interdisciplinary team in an organized unit. So what is rehab? It is not a separate phase of treatment. It begins after the acute medical intervention. And it's an integral part of the medical management and continues longitudinally to acute care, subacute care, adult community integration. Where rehab can be done, as per ABMR guidelines, you have these 6 places where rehab can be done. First is a stroke unit, acute stroke unit, then an inpatient rehab unit, a daycare rehab unit, an outpatient care, community or home-based programs. Then again, guidelines available. When patients are in a stroke unit, some patients who require medical monitoring but have stable neurostatus, has processing deficits, have disability in 2 of these 6 things, mobility, self-care, communication, swallow, bladder bowel control, and have some achievable goals, need to be transferred to an acute inpatient rehab unit. I think in India, there are 2. One we have in Bombay, second thing we have in Niman to some extent. Those patients who graduate from the acute inpatient rehab unit, which means they are stable medically now, still require 3 hours therapy per day, goes to a daycare rehab unit. And those who graduate from, post-graduate from that and become better, have minimal disabilities, go for outpatient or a daycare program. A team is required, a huge team is required to treat stroke patients because they have 9 impairments. So we require a neurologist or a neurosurgeon, a physiatrist like me, or a rehab physician, nurses, physical therapist, occupational therapist, speech pathologist, psychologist, social workers, orthotist, the guy who makes the braces, nutritionist, and so on. We have the whole team with us, and we actually admit 2 new strokes every day. The guidelines are available how to form that inpatient stroke unit. For any 25-bedded stroke unit, stroke rehab unit, we should have 2 rehab physicians with 1 fellow, 5 qualified physical therapists, 5 occupational therapists, 1.5 speech pathologists, 2 clinical psychologists, 3 nursing staff, 1 social worker, 1 long-term care officer. These are guidelines by European Academy of Rehab Medicine, how to set up a stroke rehab unit. It's a busy slide. It simply tells the ICF model. If you have pathology, you do CT and MRI. You have impairment. The common impairment after stroke are sleep, cognition, proprioception, swallow, speech. The activity limitations or disability are you cannot read, cannot write, cannot walk, and disability is you can't do your own work. So just like you have CT MRs for pathology, there are multiple scales available now for impairments, for disability, and for handicap. So stroke rehab basically focuses on 4 different issues. First, a person had a stroke, he has comorbidities, and he has tubes. So the first important role is to manage or continue the medical management of diabetes, hypertension, and so on, which we all know how to do it. The next 2 are how to train people for sensory motor function and functional training. And third, how to train for cognition, swallow, speech. And fourth, psychological, psychosocial issues. So a rehab prescription, my prescription for rehab, actually for 2 pages, minimum 2 pages, because it requires pharmacological drinks, need for Botox or not, splinting, need for casting, orders for speech language therapy, orders for swallow therapy, orders for cognitive retraining, for orthosis, for physical therapy, electrotherapy, occupational therapy, and social work. And you have to tell all these 8-9 guys what has to be done. Therefore, that's a complete prescription for rehab at the time of admission of any stroke or brain injury patient. So how can you train sensory motor function? The guidelines available, when to mobilize a patient in the ICU or a stroke unit. Don't mobilize if BP is more than 180 systolic or less than 100, if GCS is less than 8, SpO2 is less than 94, for COPD less than 88, heart rate more than 100, and severe neglect, which can affect. You can make a person sit out of bed. If guidelines are available, I can give you the slides afterwards. Again, guidelines are available to when to mobilize, when not to mobilize, and when to make only person sit out of bed. Even in the ICU on day 1 post-stroke. There are some machines available now. It's called as Arigo. We used to have a tilt table earlier to train the patient up. This Arigo is an electrical tilt table with a FES system to move your legs. So a patient who's actually GCS 8 can be made to stand even in the ICU with leg action pumping by an FES system, so you can prevent DVT in that. There's a trial that shows that very early rehab trial for stroke if you mobilize patient on day 1 of stroke, what happens? It shows that you can achieve your target interventions with no increase in mortality. So it's very, very safe now. Now he's come out of the ICU, come out of the stroke unit. He needs training, he needs physical therapy. That happens everywhere. But now a lot of technology has come, a lot of scientific evidence have come to improve motor functions. This is called as a body weight support system. A person with a stroke, he can't even stand. You make a body weight support system, offload his body weight, put a treatment, he can actually walk on the machine. It is a crude system. Now we have robotics. It's called as Locomat. You can actually, even a C5 quadriplegic can walk on this machine. The concept is you can offload the body weight. There's a robot which gives you the alternating movements and have a treadmill below. We did some research 8, 10, 9 years back. We did a RCT of that, and we have shown even in chronic stage, patients more than 6 months post-stroke who were not able to walk were able to walk with this treatment for training for at least 6 weeks, even 6 months post-stroke. And now the Cochrane review says that 1 in 5 patients with acute stroke who wouldn't have walked can walk if they get this treatment within a time window of first 2 to 3 weeks. So 1 in 5 stroke, 20% of strokes can walk if they get a comprehensive care along with Locomat training. It is the most potent intervention for stroke, in better than IV TPA or clot retrieval in long term. If a person can't stand, you can put a harness, you can train for his balance. This is a biofeedback device with a tilted platform and a screen in front of you. You can make a patient stand day 4 out of stroke unit into a therapy gym with a simple system. Start understanding how to bear weight on the right extremity. If it works, we published 6-7 years back, both in acute and chronic strokes, simple training every day of half an hour of how to understand how to bear weight on your involved extremity can lead to a better functional outcome at even 3 months and 6 months post-stroke. Something called as FES, you can electrically stimulate a local muscle which is not working properly. The most common used prescription called as Walkade, which is given for ankle dorsiflexor weakness. So a person who trips when he walks, he drags his foot, doesn't want to be an orthosis, you can just put a small device, a small portable device. You can just put a electrode at the ankle dorsiflexor muscle, and it will give you a jerk when you are doing your swing phase and prevent a toe drag. People have Xbox now, people have Kinect at their home, and people who can sit on a wheelchair, and if they play their games with virtual reality on Xbox or Kinect, improve their hand function. There's a Cochrane review says that even in chronic stroke, you can improve the reach out and grasp just by playing simple games on your home TV. People now using mental practice. We all rehearse before we come. So if you rehearse a movement, it can improve the outcome in next 3 months. If you rehearse every day your movements and follow a particular pattern, lead to better motor recovery. Mirror therapy was used for phantom pain earlier. Now even for distal recovery for stroke, mainly ankle and hand weakness, trained with the simple mirror training, it can trigger the mirror neurons in the brain and lead to better motor outcome. CIMT is a new concept. All therapies were focused on the involved extremity. So a new concept came called a learned non-use. That in spite of having some power in the right hand post-stroke, I'm not using it. So if I block your left hand and ask you to use right hand purposefully for 3 hours every day, even in chronic strokes, the hand function improves. It has the most recent guideline says that CIMT is the most potent intervention, doesn't require any equipment, just training every day by using your own hand to improve a functional outcome. Just like we have Locomat for lower limb, we have now an Armeo for upper limb. I have all the videos, can't show because the lack of the time. Armeo is a robotic hand trainer. So if you don't have power in your hand, sit in front of a computer where you can play a game or a functional activity, and robot will help you to do the movement which you cannot do. You can now do brain stimulation. You can do non-invasive 2 things, a transcranial direct current stimulation or repetitive transcranial magnetic stimulation. People are now using both for motor recovery as well as for language recovery post-stroke. And one of the first papers where they have shown if you do low frequency RTMS on the opposite motor cortex, you can reduce the transcausal disinhibition. That leads to better recovery of the hand function post-stroke. They use drugs now to improve motor recovery. The famous trial is the FLAME trial. 9 centers in Europe, they have given fluoxetine 10 milligrams day 5 post-stroke for next 90 days in MCA infarcts, and just see the outcome. The NHS score scales at day 90 was 53. This is the fecal mass score scales. Out of 90 was 53 in the fluoxetine group, 35 in the placebo group, 0.0006. For the lower limb scores, 24 to 18, upper limb score 29 to 16. Significant difference, 0.006 difference in motor recovery just by using fluoxetine from day 5 to day 90 in acute strokes. People have shown if you use these new technologies, you can actually have some functional improvement which correlates with the functional MRI findings. So if you have functional MRI showing activation in the supplementary motor area or the dorsal cortex that relates to improvements in the functional behavior, it's a simple evidence to show that these things work. What will hinder this whole treatment is spasticity. We know how to manage it, but now botulinum toxin is now being approved as per the guidelines. It should be offered as a treatment option to reduce muscle tone and improve passive function with spasticity level of recommendation, and should be considered to improve the active functions also. You can do botulinum toxin with surface marking, you can do with ultrasound guidance, do with USG guidance, you can do it with electrical stimulation or by EMG. All three are equally good. It depends what you are being trained for. But research have shown that if you do with ultrasound guidance, you use 30% less dose and 30% better outcome because you directly see the muscle you are injecting inside. So first was motor function. Second is cognition and behavior. We all know people go into coma, they come out, they in the vegetative state, become person vegetative state, can be in memory conscious state, locked in syndrome. We all know this. But we also know that each part of the brain do different functions. Frontal lobe does something, parietal lobe does something. But people with stroke, we primarily focus on their physical component. We forgot that stroke, MCA stroke happens in the frontoparietal area, AC happens again in the frontal area, which causes multiple type of deficits. They can have memory problems, attention problems, concentration, processing, and so on. What can you do for that? We have even reported a person, a lady with stroke, who says, I have 9 limbs coming out of my left hand, called supernumerary frontal limbs. People have personality and behavior issues, they have depression. We even reported that most common in India versus West are different. The most common reason for post-stroke depression is the demographic variables, not the functional status. So if you have good social support, you can prevent depression in stroke patients. And 1/3 of stroke patients will have depression anytime in their whole lifespan. Even in the acute stage, in the first 15 days, 1/3 of stroke patients have depression, need to be identified and treated. They have attention problems. A lot of drugs now are available to improve the cognitive outcome after stroke and brain injury. The commonly used stimulants are amantadine, methylphenidate, bromocriptine, and modafinil. But the most important thing in this trial, which came actually in brain injury, if you give amantadine in 2 weeks post brain injury, in people who are in vegetative state or minimally conscious state versus placebo for next 3 months, what happens? In the amantadine group, most of the patients progress towards moderate disability, whereas in placebo, most of them remain in the vegetative state. So amantadine or dopaminic agonist is a very good intervention to improve attention or even go one level higher up in severe strokes and brain injury. Many patients in that stage have neurobehavioral syndrome. We all know medically what has to be done. The new concept is called as environmental management. If you have patients who are agitated in the stroke units on the ward, what you need is simple, is a Craig bed or a floor bed. Put 4 mattresses on the ground and 4 mattresses side up, put that guy alone in a cool environment on the floor, in 48 hours, he'll come out of it. If all these medical factors have been ruled out, called as Craig bed concept. We have even shown that when they have depression and their cognitive issues, the quality of life goes down significantly. So they require an integrated approach to manage their cognitive and behavioral problems, which is called as cognitive rehabilitation. You need trained psychologists who can assess and do a neuropsychological assessment to find out the defective link. It's called as Luria's functional system. It shows that the assessment is done to identify the defective link in the functional system that can be replaced by intact link, so we can restore the signaling pathway. So if you do a full neuropsych assessment, identify which system is not working, you can now target by doing by cognitive retraining as well as by giving some pharmacotherapy. Next is aphasia. We all know aphasia. It is 8 different types. The test being done is called as VAB, or a Western Aphasia Battery. You can identify 8 different types of aphasia, anomic, conduction, and so on. Multiple approaches are available now to improve language after stroke. Simple as speech language therapy. People are using music. They use constraint-induced aphasia therapy, which means you make 5 people sit together of aphasia, ask them not to use gestures, just try to speak. Do it 3 hours every day. After 1 month, they can start producing small sentences. People are using pharmacotherapy, brain stimulation, even combining those things. The Cochrane review says that intensive speech language therapy is very good for aphasia, but you do it for long term. So if you can train a caregiver in simple speech language therapy, it works equally well over a 1-year period. Berthier from Spain in 2007 put a landmark paper that you can improve motor aphasia, word output, even in chronic stroke if you give memantine along with speech language therapy. And then the same group in Spain are now using donepezil along with CIAT in acute stroke, and they're actually shown with functional MRI how the repetitive naming task can be improved by addition of donepezil even in first 2 weeks following stroke. People are now combining brain stimulation with speech language therapy. So if you do a RTMS in the inferior frontal lobe area along with the speech language therapy, you get better outcome. Last is dysphagia, the most neglected things. 1/3 of people actually have dysphagia after stroke in long term, of which 1/3 is mild, moderate, and severe. The gold standard test is video fluoroscopy. I don't know how many centers do VFL. Each and every of our stroke patients, once he's medically stable, can follow commands, undergo a proper swallow evaluation along with the video fluoroscopy. You can actually document which phase of swallow is affected. It is the oral phase or pharyngeal phase or the esophageal phase. They can plan an intervention. Even if they have tracheostomy, actually put a valve there. You can put a speaking valve. People can actually eat with that. They can speak with that. And then if you can't help, something called as vital stim. Vital stim is a electrical stimulation device to stimulate the swallow system of the pharyngeal muscles. You can use it for dysphagia, also for dysarthria. It gives very good result when combined with speech language therapy. The last one, bladder and bowel. We all forget. Always remember, stroke can affect bladder by 2 different ways. If it is a suprapontine stroke, it will just cause detrusor overactivity. If it happens pons or below pons in the brainstem, it can cause detrusor overactivity along with dysynergia, because the center is there in the pons. And we actually published this thing a few years back. 95% of our stroke patients at day 24 had neurogenic bladder, 95%, of which 66% had only detrusor overactivity, and the 1/3 have detrusor overactivity with dysynergia, which we don't actually target. We just remove Foley's catheter, we never check the PVR. And you can manage these simple things by drugs. You can, if you have a detrusor overactivity with dysynergia, give anticholinergic medication, give some antidiuretic medication, let him pee. If he has both minors, give drugs to increase sympathetic activity, and you can combine it by using self-intermittent catheterization. We don't use it, but the most effective way to drain or empty a bladder is not a Foley's or Superbig catheter, it's a self-catheterization. With the opposite hand, you can do it. Last, people come out of the ICUs and stroke unit and not pass motion in the last 7 days. Always, the day the patient can sit out of bed, put him on a commode chair every morning. In next 7 days, cycle form again, because bowel the feature of reflex. Always remember, the day patient sit out of beds, put him on a fixed time every day on a commode chair with a decent suppository. In next 5 to 7 days, reflex will develop again. He'll pass motion, no need for enemas in long term. And the last thing, health class. A full team is required for rehab, and patients don't understand so many complex things. So what we do every week, we do a health class, and most of our patients or their relatives come in that class. Some team members spend 1 hour with them once in a week for them to know what actually we are doing. Are there some prognostic factors for stroke recovery? The negative predictors for stroke recovery are coma at onset, bad incontinence, poor cognitive function, serious hemiplegia, lack of return of motor activity at 1 month, a prior stroke and hemi-neglect, significant cardiovascular disease, and large cerebral lesion. If you have these patients, they might not do well long term, and they are old, they might not do well in long term. Is rehab efficacious? Does it actually help? There's a meta-analysis that shows that organized post-acute stroke care by a physician-supervised multidisciplinary team whose work was coordinated to regular weekly meetings dedicated to rehab, 9 trials, 1,500 stroke patients, reduction in death, installation, and dependence, which means stroke rehab, there's strong evidence that it works in long term. How it actually happens, if you see in the beginning, in the first few hours, we reperfuse the brain. Within the next few days to weeks, the impairment started improving. And at that time, if you add another dose of therapy, medication, RTMS, you can have a long-term better outcome. So the whole rehab was primarily dedicated to treatment of disability, which means it's already 3 months, he already has hemiplegia, cannot walk now, not give him a wheelchair to manage him. No, the current concept is to target the impairment. You treat weakness with robotics, you treat spasticity with injections, you treat aphasia with medications, prevent a disability to set in. That is the current focus in rehab. Thank you very much.
Most of the rehab centers, they don't accept tracheostomy patients for rehabilitation. Do you accept tracheostomy patients, and is there any kind of respiratory rehabilitation we provide? Because most of these quadriplegic patients and most of the stroke patients, when they have tracheostomy, they develop recurrent lung collapses and they develop pneumonias, respiratory tract infection.
Yeah. We accept all patients, and Dr. Anand is here. We accept all patients from ICU, and in fact, most of our patients are on tracheostomy. The simple key is we don't treat tracheostomy care. If you can do a simple dye test and document that there is no dye in the suction, it means that the basic swallow reflex is okay. He cannot eat, but you can put a speaking valve there. So if you put a speaking valve, you are training the swallow system every day. So you start half an hour training every 2 hours, and then make it 1 hourly every 4 hours. And gradually next 5 to 7, what you will see, that body learns how to compensate. And we have decannulated most of our patients by this simple strategy.
And we don't have video fluoroscopy to do swallow test, but can we use this dye test to replace that?
So there are 2 things. One is to check for basic swallow reflex. Second, can he eat or not? These are 2 different things. For decannulation, you require a dye test. For feeding, you require a swallow assessment. You can do a bedside 3-ounce swallow test. You take a water, 3 ounces of water, give. If he doesn't cough in the next 10 seconds, he can take some thick liquids. And VFL, we all have X-rays in our hospital. We all have fluoroscopies in that X-ray system. We don't know that how to use it. Every hospital has an X-ray, and every X-ray now has a fluoroscopy system. We have to just go there, sit, see for 100 patients and understand how it happens. So I also, no one taught, I have to learn on my own. We all have it. We're not using it.
Thank you, sir. Thank you.
Thank you very much for all the participants. I think this will conclude this section of the meeting. I think it was, special clapping for all the speakers who gave us such information. Thank you very much. I think, Nabil, lunch is next, right? I guess not. Lunch is next, right? Yes. Okay.
This is lunch and at Taj Krishna. So it's in the atria outside. So I would request the delegates to gather back here. But a quick reminder, all of the talks that will be presented at this symposium will be available in electronic format with permissions from the speakers. So we'll give you you can log on to the website, or alternatively, you can leave your email addresses so we can email the presentations to you folks. That way you have them. I know some of us might have missed a few pieces of the presentations. So enjoy the lunch. We'll see you after the lunch. Thank you so much. Being in the ballroom here to resume our sessions. I think we took a few more minutes, but the food I'm sure deserved a little bit more time. The first talk for the post-lunch session will be by Professor Kaul. He'll be talking about the burden of stroke in South Asia and risk factors. This particular session is primarily focusing on the burden, the challenges that we face on a daily basis as vascular neurologists or primary care physicians when we encounter stroke patients. There's so many reasons that we face. Some of them are unfortunate, where patients making within the time window for TPA don't receive TPA for several reasons that will be discussed today. And the goal is to emphasize on these particular challenges, which will actually determine how the future of stroke care will be in South Asia. So this session is one of the most important sessions of today. And I hope the things that come out of this session are paid attention by the media, by the government, by the private healthcare systems in the country, and a common understanding or something comes out of it so these challenges can be faced. There is no way other than finding solutions to these problems that the global burden of stroke can be addressed. So that said, without any delay, Professor Subhash Kaul. This particular session, I would like to request Dr. Rakesh Khatri to chair it, and also Dr. Vengamma, who is the head of neurology, SWIMS Tirupati. Please welcome both the chairpersons. Thank you, ma'am. Thank you, sir. So, would you like to sit right here? So,
Vengamma, can I start? Good afternoon. Post-lunch sessions are always very challenging. They are best for the audience because this is the time when they can take a short nap. Speaker cannot obviously sleep because he'll fall down and it'll be noticed. But it's particularly challenging for the chairpersons because they're exposed to everybody and they have to keep their eyes open. Where is South Asia basically is the question. We are saying stroke burden in South Asia. Well, South Asia is where we are actually. So it concerns us. South Asia is same. If you take Southeast Asia, it is not same. Because in that Japan also comes and other countries are very advanced. We have nothing in common with them. But South Asia, we are all together. That is what we call SAARC countries. Basically it means we are poor countries. So poor nations of the world is Southeast Asia. And if you see, this is the map of the world, and this is where you are at this time, this dot. It is almost where you are in Hyderabad. And this whole Indian peninsula with the Pakistan and Nepal on one side and Bhutan, this area is South Asia. So these countries have made a conglomeration of, it's also called SAARC countries, and these are the main players of South Asia. This is alphabetical order strictly. Afghanistan, Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka. They are poor and they are populous. South Asian region makes up more than 40% of the developing world. South Asia constitutes 22% of the world's population, and three main players, India, Pakistan, and Bangladesh, are among the top 10 most populous countries of the world. What is the stroke burden? By stroke burden, we mean what is the incidence, that is the new stroke patients which occur in a given period of time. What is the prevalence, that means how many patients exist at one given period of time. What is the mortality? And WHO has also coined another term called disability adjusted life years, DALYs. And what are the determinants of these markers of stroke burden? Is the risk factor. If you have more risk factors, you have more burden. There are some areas in the world where there are least risk factors, like in Mediterranean or some other areas, where people don't get vascular disease at all. They don't have risk factors. But we are just full of risk factors. There is some element of genetic predisposition, predisposing conditions. Exact stroke burden is not known. If you go scientifically, what is exact burden as it is in the European and America, it is known because of the various well-evolved systems of counting. Here, it is just by approximation. Exactly, we don't know. Because the tools which are used to measure stroke burden are not available uniformly and completely in our countries. These are the usual tools: scientific publications, particularly scientific publications of population-based surveys, door-to-door surveys, death certificates, insurance claims. In fact, these are the tools by which they measure stroke burden in developed countries. And we have limitations in all three of them. If you look at publications in our area, you can see that whole of this area, India and all, we are below here. We have less publication. In fact, Pakistan is even below us. And Nepal and all hardly have any publications, below 10 publications on stroke in the last 10 years. So at least amongst our neighbors and this, we are, whatever data is there, it is driven by India, followed by Pakistan. And other countries hardly have any published population-based data. So there is a limitation to measure. But based on whatever is available, based on the population of 1.2 billion in India, the incidence of stroke is roughly 150, we would say. It's roughly 150. One study has also shown 262, but overall you should say 150. That means 150 per 100,000 population get a new stroke every year in India. Now compare this with Pakistan. They don't have many or even a single well done population-based study, but they estimate it to be more than India, which is 250 per 100,000. In Bangladesh, it's not available at all. Our prevalence is latest prevalence done on Calcutta study about 540 per 100,000. Prevalence means the total burden, the old strokes and the new strokes combined. And Pakistan is much more than us. If we go by their data, it is about 10 times more than us. But obviously there are a lot of flaws with that study. They are limited and they are not done. But what is common here is that it is quite significant in this part of the world. And in fact, we often show this this slide, is that if you look at the studies of the last 30 or 40 years, the prevalences and incidences, at least in India, have gone up remarkably. In 70s, in study done in Vellore, it was shown an incidence of 33, and now the latest is showing 145. Of course, done in different parts of the country. Prevalence, the earliest was 56, and now it is 540. And if you look at USA in comparison, from 146, they have come to 81. And prevalence from 700, they have come to 612. So this is a kind of an irony that in the developed countries who have all the infrastructure, who have everything, this stroke has been contained and actually it is stabilized or a little bit coming down. But we in South Asia who don't have infrastructure, who don't have even the means to deal with the stroke, it has come on us like an epidemic. And all of us, you must be seeing in your day-to-day life, if you visit the hospitals, casualties, or look even among your own relatives, you find that stroke is happening very commonly. So there is a stroke epidemic on us. What is the cause? One of the very important researchers, cardiologists from our country, Dr. Srinath Reddy, who is the president of the Public Health Foundation now, has written a very thought-provoking article on causes of arising stroke in 1998. And these are the terms in that article, is that there is a demographic transition in our population, which means lifespan has increased. From a lifespan of 47 or 48, 50 years ago, now it is touching almost 70. And stroke is a disease which is associated with age. So with this demographic transition, stroke is increasing. Then there is an epidemiological transition, which means now more and more villages are getting converted into urban areas. And urban areas themselves are getting more urbanized. So there are lifestyle related diseases. There's fast food culture. There's uncle chips. People don't walk at all. So all these things is coming on, coming on a population which also seems to be genetically predisposed to vascular diseases. So we have got now these new risk factors. India is thought to be the diabetic capital of the world. So with those risk factors, we have these new risk factors, and unfinished agenda is still there. Rheumatic heart disease is still there. We still get patients of mitral stenosis with hemiplegia. We still get tubercular meningitis with hemiplegia. So there are new risk factors and there is an unfinished agenda. And unfortunately, in some parts of the world, some parts of India, there is better survival. But better survival leads to more disability because they survive with disability. So all this has led to a very big stroke prevalence and population in our countries. Now, although we say that the longevity has increased, yet interestingly, stroke strikes us young. Compared to Western countries, stroke comes at least 10 years before. Even cardiovascular disease comes at least 10 years before. And it is thought it is because of premature atherosclerosis. People start getting atherosclerosis at the age of 30, 35-year-old stroke patient, 40-year stroke patient. 40-year stroke patient is thought as stroke in young in Western countries. But it is a reality here because of premature atherosclerosis. This was one of the 6-center hospital-based studies where it was found that almost half the strokes occur in people when they are in their productive age, 40 to 60. And 40% come after the age of 60 and 16% less than 40. So that was about the stroke prevalence. Now, what about mortality? Even though we say that there is better survival, which is true, in spite of that better survival, most patients, the mortality is highest in our countries. Mortality is highest in India. Again, all these graphs are from WHO, and you can see that this color shows maximum mortality, 200 per 100,000 every year, and you can see all this area, India, and all you can see this compared to the other countries. So mortality also is very high. According to WHO estimates, 86% of the deaths related to stroke worldwide occur in developing countries. And South Asia is thought to be the highest contributor to stroke mortality in the world, accounting for more than 40% of the global stroke deaths. In this region, stroke mortality rates might be as high as those for coronary artery disease, and both stroke and coronary artery disease occur about 10 years earlier on average than in the rest of the world. Every 45 seconds, somebody in India dies of a stroke. And of course, this is the disability adjusted, it's a mathematical model, and this also is maximum in India. Now, people have been looking at risk factors for the last 40 years. This is 1989 study by ICMR, by Dr. Dalal, who is one of the founders of stroke awareness and stroke literature in our country. And at that time, in 89 study, high blood pressure, high blood sugar, hyperlipidemia, smoking, rheumatic heart disease, and tuberculosis were thought to be the main risk factors. Interestingly, Dr. Dalal also found that low hemoglobin is also a risk factor for stroke, which is counterintuitive in the sense that people think of polycythemia as a risk factor. But I think people more and more are realizing that that low socioeconomic status itself is becoming a risk factor. There are a lot of studies being done in slums. There's a study done in Ludhiana by Dr. Jairaj Pandian these days, and he has written a review article, Poverty and Stroke. It seems poverty is also a risk factor for stroke, and low hemoglobin also is a risk factor. And same is in Pakistan also. There's the slums of Pakistan. There's a Karachi study which has shown almost 21% of them having one-time stroke. So therefore, all of them are risk factor and they work together. Now, I was just looking at in fact, myself and Dr. Wasif from Pakistan and another collaborator, we wrote a review article in Nature Reviews in Neurology, And we analyzed this whole data, and this is table from that article. The risk factors are almost common. There's a difference, few numbers. Otherwise, hypertension, you can say India, Pakistan, Bangladesh, very high. Smoking is very prevalent, maximum in Bangladesh. I think Bengalis as such, everybody smokes in Bengal. So it's 53% there. And we have other problem is we have young smokers. I mean, people in the poorer strata, they start smoking from the age of 15 only. So diabetes, as I said, is very common, dyslipidemias. And atrial fibrillation is associated with rheumatic heart disease in our country. But now non-valvular atrial fibrillation also is being picked as the age is advancing. But still, it's not such a big risk factor as it's in the Western countries, where it's the main cardioembolic. So basically, our risk factors are almost same as West, and in addition, we have some of our own risk factors. But the Western risk factors, we all share. We have all of them, like hypertension, smoking, diabetes, dyslipidemia. Now, these are the newly identified risk factors, which all of you who treat strokes are seeing it. Particularly in young strokes, homocysteine is very common, and some people claim it is associated with vegetarianism, and some people claim it is genetically driven. But we are seeing it more and more in the younger population. Obesity is a very important risk factor, and some of our studies have shown that there is a genetic polymorphism associated with the phosphodiesterase gene, which was found basically in Iceland first, could not be replicated in most parts of the world, but studies done here in Hyderabad and also in some parts of Pakistan and found that STROK1 gene, or which was found in Iceland, we also have that polymorphism here. So therefore, some genetic predisposition plus all these risk factors lead to a high burden. Now coming to the stroke types, ischemic versus hemorrhagic. Like in most of the world, ischemic strokes predominate. We have a hospital-based registry, about 3,000 patients and across 10 years, and we also found, and everybody, I think Dr. Murthy also has a registry, we find that 80% are ischemic strokes and 20% are hemorrhagic strokes as such. But there are some pockets in this country where hemorrhagic strokes are more common. And these are Northeast, which means Assam. These are Bengal. In fact, there's a population-based study in Kolkata. They have found about 32-33% are, rather than 20% are hemorrhagic strokes. And in Kashmir, they have not published, but by observations and by some textbook, they think that hemorrhage is more common than ischemia in Kashmir. It's a very interesting phenomena. Why is it like that? But people claim it is because of very high blood pressure and very high salt intake. So in Pakistan also, in fact, some data shows that hemorrhages are common. So overall, it is ischemic more common, 80-20, but some pockets in these areas have shown predominance of hemorrhages. We have to realize that. Now, this is another very interesting thing. What is the site of atherosclerosis? Atherosclerosis is thought to be a global disease, yet it is focal. It involves one part. And in America, they are very fond of studying this, that how many have intracranial atherosclerosis, how many have extracranial atherosclerosis. And we have found that we find all kinds of atherosclerosis here. All of you see we have carotid disease right and left. Stents are being put right and left. But intracranial also disease is very common. It's about 20-30% in various studies. So all kinds of atherosclerosis are here. You name it and we have it here. This was our initially pilot data of subtypes of ischemic stroke. So you can see cardioembolic, extracranial, intracranial lacunes, everything exists here. Okay. Now, is there anything specific which is specific to South Asian countries or particularly in India which is different? These are few things. One is that mean age, which I already said, it is 10 years younger than the Western countries. Premature atherosclerosis is common. Infectious etiology, it is coming down, but still we see it. It's not totally conquered. Anemia also has been noted to be a precipitating factor. Non-valvular atrial fibrillation is not as common as Western countries. We have some limited data where we are finding about only 10% of cardioembolic strokes occur because of NVAF, but it is increasing. As the longevity is increasing, it's increasing. I think some studies are in progress to look at that. Intracranial atherosclerosis is common. And there are some case reports which have shown very funny and unusual causes of stroke, at least from a Western point of view, one of which is a scorpion bite. And there are some reports from India and from other countries also, Pakistan and all, where scorpion bite leads to hemorrhagic as well as ischemic stroke. And also there are some interesting case reports on squatting related strokes, and it is thought because Indians are in habit of squatting, during that time blood pressure may rise and cause a rupture of the blood vessels, but these are very few reports. So there was a meeting in 1998 in Montreal which was organized by Lancet, and Lancet does these meetings, theme-based meetings, and I had an opportunity of attending that meeting in Montreal, and Hachinsky and all, they were there. And this stroke epidemic term was coined there. And with me is one very gentleman who became a very good friend of me from Pakistan. He's sitting here. His name is, I think he's from Karachi. His name is Vadera probably. Dr. Vadera and myself, we are sitting together. And it was announced there that the stroke has been contained in the Western countries. But now epidemic has started in the India and Pakistan and developing countries. And you can see Vadera is obviously visibly worried, but I'm trying to put on a smile. Whereas all the Western people are very happy, because stroke has been contained there. And still stroke epidemic term started from that point, from 1998, and we are all worried about it and thinking about it. So in summary, I would say that based on what all I have said, population is maximum in South Asia. Stroke also is maximum in South Asia, but infrastructure is minimum in South Asia. And if we talk of global campaign against stroke, it will be incomplete without the involvement of South Asia. As long as South Asians have stroke, the fight against stroke is not complete. So I think that is what I would like to tell our American collaborators. Thank you very much.
Canalization by thrombolytic therapy. Unfortunately, in spite of good evidence, it is underutilized throughout the world, more so in the developing countries. I was given to talk on what are the challenges we are facing in giving thrombolytic therapy for patients with ischemic stroke. As Dr. Subhash has already shown, what is the region which is considered South Asia. South Asia, roughly about 2.5 billion of people are living, and the health infrastructure is very, very poor. The amount, the GDP, percentage of GDP spent on healthcare is single figure, less than 5% most of the countries, and insurance systems are not well developed. So he has touched upon this point as far as incidence of ischemic stroke. So I just want to see, these are the, as morning I told, World Health steps protocol determined these four cities, and it gives an incidence of roughly average incidence of 145 per 100,000 population, and roughly about 75 to 80% of them are ischemic stroke. If the projected incidence cases of all types of stroke at the present population of 1.3 billions in India is about 18 lakhs we call in Indian currency, and ischemic stroke is roughly 15 lakhs. So I got the information from the Boehringer's data. Only last year 6,000 thrombolysis were done. 6,000 patients received thrombolysis. So that means it is 0.4% of ischemic stroke patients received thrombolysis last year. It is pathetically very dismal figure. So what are the barriers for not giving thrombolysis therapy in ischemic stroke? They can broadly be classified into pre-hospital barriers, in-hospital barriers, and personal barriers. Pre-hospital barriers include stroke awareness among the population, awareness of stroke symptoms among patients, awareness of thrombolysis in ischemic stroke among practicing physicians, connectivity, the transport system and ambulance services poor healthcare resources. Most of the data which I am going to talk is from India, because the maximum thrombolysis is being done in India, and the other 3 countries where thrombolysis is being done is Pakistan, Sri Lanka and Bangladesh, but the numbers are very few. All these pre-hospital barriers result in delayed arrival of the patient at the emergency departments. In hospital barriers, most of the, even the so-called corporate hospitals and big teaching institutes have not having stroke teams and or stroke unit, dedicated stroke units, and delays in the door to CT and door to needle times. This is because of lack of protocols and administrative delays. And personal barriers, which is most important, is non-recognition of stroke warning symptoms, and the purchasing capacity of the individual is very poor. Most of the work about stroke awareness is done by Pandan, my good friend Jairas, from northwest part of the country. So when the public awareness in stroke in northwest India, only 55% recognize that it is a brain disease, and only 2/3 of the patient has an idea that paralysis could be because of brain stroke, and some felt it could be because of vessel occlusion, or 14% felt it could be a rupture. What are the determinants what are the factors that determine that the individual to know that brain is the site of the stroke? Higher education, upper socioeconomic status. Obviously, these 2 factors are likely to determine the awareness. And when it comes to awareness among the patients, awareness of initial stroke symptoms is only in 27% of the patients interviewed. That means roughly 75% of the patients are not aware that they have a stroke. Higher education, younger age were associated with this knowledge. Health-seeking behavior is only 1/3 of the patient approached immediately hospital, and a lot of patients, that are 2/3 of the patient approached practitioners, and the remaining asked relatives' help regarding what to do next. This is our study. So when to suggest that the awareness of among the physician is poor. See, this is the hospital, care hospital, that is the distance. We got the patients between 2008 and 2010. We analyzed our data. So if the physician, they went to the nearest hospital, if the physician is aware that thrombolysis can be given in this patient, and if he had referred in time, about roughly 50% of the patient would have been benefited by thrombolysis. That shows lack of awareness among the physicians. And other possible causes also, as Jaira's study shows, lack of awareness of stroke symptoms among the patients. The other is connectivity. Connectivity is very, very poor, and more so with a chaotic traffic, as Subhash has shown. So to reach from here to our care hospital, which is a walkable distance, it may take some time, half an hour. So mode of transport or arrival at the emergency department is often self or aired. We have in our state 108 ambulances, so good network, but only in our study only 1% of the patient utilized the ambulance services. Most of them arrived on their own transport. So the only of the 641, only 65 patients arrived within the window period, because 2009 the window period is expanded. So if you include that, 10% of the patients only arrived at the appropriate time. And similar were the figures from 14.9 is JERA's study, and 31% is by Pondicherry study. That is a relatively high, that 31%, because that institute is located in a rural area. Surrounding area is mostly rural. Again, if you see the people who arrived within the window period, most of them are in and around the hospital, and the distance is 5 to 10 kilometers. So it's clearly showing it, connectivity, transport system, ambulance services are poor. Otherwise, we would have got some more patients in window period and we would have helped them. What are the in-hospital barriers? Delay in administering IV therapy. In our study, door to needle time, because we have a well-established protocol and schedules, mean is 9.5 plus 20, the average is 5 to 15 minutes. And now I am working in another care hospitals, another big hospital. Now door to needle time almost 50 minutes, 45 to 50 minutes we are able to thrombolize, because we have well organized protocol. So, but in most of the, particularly government hospitals, Subhash may agree with me, that because of inherent lethargy in the support to staff, there will be much delays in both door to needle time. And the other possible causes are administrative causes. The hospital expects the patient to pay the cost of thrombolytic therapy. Unless they pay, they won't give the vial to administer. We have to struggle with our administration. Okay, we take the responsibility, provide it. Now they are providing it. That is one possible reason. And again, there can be a delay from the pharmacy to EMD in drug delivery. So they are preventable delays. And coming to the personal value, the most important is the finances. Total patients within window period, that is 65, 10%. Eligible patients for thrombolysis are 62. 3 we could exclude because hemorrhagic conversion, massive and recent surgery. Affordability, if you see it, most of the patient, the payment is out of pocket, 72%. The 28%, they have either insurance or credit facility from the organization where they are working. And 12 patients we could not do thrombolysis because they could not afford the cost. Related direct cost, when I calculated, this is the 2010 figure, that at that time the 60 milligrams roughly, we will be giving 50 to 60 milligrams most of our patients because of weight, low weight. Market rate price was 65,000 population. We calculated costs for 2 non-contrary. This is these are the costs, government hospital costs. So if you come, the total cost comes to 77,400 rupees or $1,478. If you convert it into gross national income per capita, per international dollars, it comes to 5,240 international dollars. That means in India, the per capita international income is 5,240, and the patient will be spending roughly 48% of his GNA per capita on IV thrombolytic therapy at one time. So half of his income he has to shell down to get the treatment. And this is the GNA and PPP, that is international dollars of the South Asian countries. I could get the figures, and if you can see it, roughly for anywhere 1/3 to 60% they pay as direct costs for their. This is only for TPA, not hospital and things. This is an enormous burden, financial burden, based on their per capita GNI. So, but the good thing is there is increase in tendency of utilization of thrombolytic therapy. This is the data from the Boehringer-Ingham's data base. There is steady increase. In last year, the number of patients received thrombolysis is 6,000. So, but it is a minuscule when compared to the burden of stroke. And this is Panden's price. Ours also is similar figure. I didn't calculate that. So there, within the institute also there is little increasing tendency. We have to go a long way to implement thrombolytic therapy to most of the patients. There are several barriers we have to overcome to make it as effective and the first line treatment for stroke, ischemic stroke patients in Southeast Asia. Thank you for your attention.
Thank you, Dr. Murthy, the fact. And all of us face, I think, more than other things. Of course, one is awareness, second is the financial constraints. I think one good thing is after this state government insurance schemes, like I was told that in Tamil Nadu, these IVIGs, IVTPA is covered under Arogyasri, like our scheme, they have got their own scheme. That's why last 6 months to 1 year, I was told even in the government hospital of Madras Medical College, the usage of IV TPA has gone tremendously. That's what Dr. Banu was telling. I think similar thing we should do, because unfortunately in our state government, this TPA is not covered under that NTR Vaidya Seva. Now the present name has been changed. I think we should all put across and see when the neighboring governments are doing and similar, so that more and more usage can be done. That's what I felt, because the last 6-7 months I was told that even in government hospital, Stanley and the Madras Medical College, the usage has become dramatic. Numbers are improved because patient need not have to think of that money, this one, it is the government insurance. Not sir, not thrombolysis also, sir, it is there. No, it is there, sir. Dr. Banu, and she was telling me they have increased.
Maybe Tamil Nadu government, I am talking about Andhra.
No, that's what I am telling, sir. Neighboring states are doing. I think we should tell our government to include in that and do it.
Is available.